my thoughts on mechanical ventilation and cardiopulmonary interactions, especially in cardiac patients. I don't see any of you, so to me it's important to have an interaction between me and those who are listening. I think the most that we can do is a chat box. So feel free to shoot me a question or any comment anytime, and then I'll try to answer them as soon as I can. Okay, let's start. So for today, we're going to talk about the basics of mechanical ventilation. I don't know how much of ventilator management you do in your centers, but I'm just going to go over some of the terminology, some of the settings, and issues on gas exchange, which will be useful in the subsequent part of the lecture. And then we're going to talk about cardiopulmonary interaction. Specifically, we'll talk about the interaction of positive pressure ventilation on the right side of the heart, pulmonary hemodynamics, the left side of the heart, and the interdependence between the left and the right ventricle. Okay, so shown here is a pressure time curve. On the y-axis is the pressure delivered to the patient, and then the x-axis is time. So whenever we put someone on the ventilator, more often than not, we put them on some baseline pressure, which we call PEEP, or positive end expiratory pressure. That PEEP is raised to a pressure above it, which maxes at peak, or peak inspiratory pressure, and it's held there from point A to point B, which is what we call the I time, or inspiratory time. Once inspiration is completed, then expiration occurs. So you have TE, or expiratory time, which is from point B to point C. At that time, the pressure goes down to the baseline pressure, or PEEP, and then when the next breath comes in, pressure goes up again, and you end up with a peak inspiratory pressure. The ventilators that we use right now are with what we call positive pressure ventilation, because the pressure that we're giving is above atmospheric pressure. In the older times when ventilators were first invented, and during the polio epidemic, what they used was a negative pressure ventilation, which is the iron lung. So that simulates spontaneous breathing more closely than what we have right now, but I don't think anyone uses an iron lung anymore. The other important aspect that I want to point out in this slide is the delta, or the difference between the PEEP and the PEEP, is directly related to your tidal volume. So if your ventilator is set in pressure control, then you cannot set your tidal volume. So what you need to deal with is your peak pressure and your PEEP. However, if it's a volume ventilator, then it's outright to just set your tidal volume and you're all set. The other thing which I'm going to deal more later is the mean airway pressure. The mean airway pressure is the area under this curve, and as I'm gonna tell you later, this is directly correlated with PO2, or oxygenation. So how do we start our ventilator settings? So typically, the cardiac patients that we see in the ICU are post-operative, meaning they just underwent some surgery and they end up in the ICU. But it's also not unlikely that we get patients who are pre-surgery, but it's less likely for us to do that. So typically, what we start them on is a PEEP of 5 cm water. We have a PIP, say if we're in pressure ventilation. We provide a tidal volume of around 10 ml per kilo, and we do that by adjusting our PEEP. But if we're in outright volume ventilation, then we just set it at 10 ml per kilo. And then the rate is, we start them off as normal for age, unless we're close to extubation. And then the FiO2, we provide as much as needed to attain acceptable oxygen saturation. If you can see here, I didn't write something like greater than 92%, because as you know, some patients, such as the single ventricle patients, would have sat somewhere like in the 70s and 80s and the Glenn patient. So it's important to know what's an acceptable oxygen saturation for this patient, and you win your FI2 so that you provide the least amount of oxygen. But in general, in the absence of lung disease, which most of the post-op patients don't have, your FiO2 should be pretty close to 21%. Once you start reaching like 50% and you cannot achieve your acceptable saturation, that's usually a trigger for you to figure out whether there's an intracardiac shunt which was not detected after the surgery, or your lung disease is more significant than what you thought it was. So how do we play around with the ventilator? So anyone who's on a ventilator, we get gases every now and then. We look at two things. First is oxygenation, and then second is ventilation. So when you assess an arterial blood gas, you should assess both, and it's not just oxygenation or it's not just ventilation, because the way you manage your ventilator will affect your oxygenation and your ventilation. So when we talk about ventilation, we look at the PO2, and then when we assess ventilation, then we're looking at PCO2. So first question. A 6-month-old boy was admitted to the PDICU intubated after total repair of tetralogy of Afterload. There was no residual intracardiac shunt after surgery. Patient's arterial blood gas was 7.30, PCO2 of 60, and PO2 of 60. Chest X-ray showed diffuse atelectasis. First question, which of the following can improve the patient's oxygenation? Increase your inspired O2, increase your PEEP, increase your PIP, or all of the above? I'll give you a minute or so to type in your answer. Okay, I have one. Okay, it's either I only have one attendee or people are shy to put in their answer. So for this question,
Vince, there's another answer from Amrita. They've written increase PEEP and PIP. Amrita, guys, just put it to everyone so that everyone will be able to see your answer.
Okay, so it just went through PEEP and PIP. Okay. So yeah, so all of the following can actually increase oxygenation in this patient too. I got someone who said, "Oh, we're doing better." Okay, so why is that? Remember when I showed you the pressure time curve earlier? The PO2 or oxygenation is directly proportional to your mean airway pressure. And your mean airway pressure, as I mentioned earlier, is the area under the pressure time curve. So that this is your area under the pressure time curve, so all of this, including that below your PEEP. So anything above the 0 line and below the yellow and green line, that's your area under pressure time curve. So anything that's going to increase that curve is going to increase your FiO2. So this is PEEP, for example. If I bring that up, your PO2 is going to go up. This is your PIP. If I bring that up, then your area also goes up, and that's also going to increase your PO2. Another way is increasing your I time, which is from point A to B. So if I move that up to here, then the area under the pressure time curve also increases. So that's also going to increase your PO2. And the most obvious thing is if you bring up your inspired O2, then more often than not, their PO2 is going to go up. Again, that's true for most cases, except if you're dealing with a huge intracardiac shunt, in which case increasing your FiO2 is not going to increase your PO2. Okay, so just to summarize that, so if you want to increase your PO2 such that if your patient is desaturated, then you increase your PIP or your tidal volume. Remember, in your PIP is directly proportional to your tidal volume. You can increase your PEEP, you can increase your I time, or you can increase your FiO2. Or if your patient is hyperoxygenated and you want to decrease your PO2, the stuff that you can do is just directly opposite the initial column. So decrease your PIP, decrease your tidal volume, decrease your PEEP, decrease your inspiratory time, or decrease your FiO2. Okay, next question. Which of the following can improve the patient's ventilation? Increasing your FiO2, increase your PEEP, increase your PIP, or all of the above? Okay, I have 1. I have 2. Okay, so that's right. For you to improve your ventilation, what you can do is increase your PIP. So going back to the pressure time curve. So initially I said, so for oxygenation, what you're dealing with is the mean airway pressure. But when you're talking about ventilation, what you're dealing with is all the area above the PEEP. So that is, if you project this yellow line all across that way and all across up to the end of the line, all the area here is what's going to determine your PCO2. So your carbon dioxide tension is inversely proportional to your minute ventilation. And this is true whether you're spontaneously breathing or not. Minute ventilation is your respiratory rate, or the number of breaths that you breathe within a particular time period, and the volume of your breath, which is your tidal volume. So anything that's going to increase your respiratory rate or your tidal volume or both is going to decrease your PCO2. Or anything that's going to decrease your respiratory rate or decrease your tidal volume, that's going to increase your PCO2. And again, as I mentioned, graphically, your minute ventilation is proportional to the area under the pressure time curve above PEEP, or what we call delta PEEP, which is the difference between your peak pressure or PIP and your baseline pressure, which is PEEP. I don't know what type of ventilator you have in your center, but currently in the US, the nomenclature for PIP is not the same for every ventilator. So there are some ventilators where PIP is actually the difference between your peak pressure and PEEP. So in reality, that's your delta pressure. And there are some ventilators where when you say PIP, it already takes into account your PEEP. So that means when you say PIP, that's the amount of pressure above 0. And this is important because what you need to remember is the tidal volume is directly proportional to the difference between your PEEP and your PIP. So if that's not how your ventilator works, you need to do some calculation to figure that out. So what are the ways to increase your PCO2? As I mentioned earlier, you can decrease your respiratory rate, you can decrease your tidal volume, and decreasing your tidal volume in a pressure ventilator means decreasing your delta pressure. That may be either by decreasing your peak pressure or increasing your baseline pressure or PEEP, but keeping your PIP the same. What does that mean? So if I keep the peak pressure the same, and then I bring this baseline up, then my delta decreases, my tidal volume decreases, and your CO2 increases. So if you want to do the other way, if you want to decrease your CO2, then you can increase your respiratory rate. Again, in a normal patient, it's the same. If you breathe faster, your CO2 goes down. or you can take deeper breaths by increasing your tidal volume. And again, in pressure ventilation, it's just a matter of increasing your PIP. Either you increase your PIP, keeping the PEEP the same, or decreasing your PEEP, keeping your PIP the same. Okay, so moving on. So let's talk about cardiopulmonary interactions. So basically, the function of the cardiorespiratory system is to provide oxygen to the rest of the body. Oxygen delivery is mathematically described as the product of your cardiac output, meaning how much blood your heart is sending to the body at a particular point in time, times the amount of oxygen that is that's carried by the blood. And that's your arterial oxygen content. And arterial oxygen content is dependent on your hemoglobin, oxygen saturation, and then your amount of dissolved oxygen, which is described in this part of the formula. The thing is, ventilatory support, so even though oxygen delivery is oftentimes thought of as a cardiac equation, the way you ventilate someone can actually affect your arterial oxygen and cardiac output. The arterial oxygen content is sort of very intuitive because if you improve your oxygenation, then your oxygenation saturation goes up, and that's pretty easy to understand that your arterial oxygen content is going to go up. However, cardiac output, as I'm going to show you later, will also going to go up or down depending on how you provide ventilation to this patient. So as I mentioned earlier, we're going to talk about the right side of the heart, pulmonary hemodynamics, left side of the heart, and ventricular interdependence. So one thing that's important to remember is that all the structures, all the cardiac structures are inside the thorax, such that anything that's going on in the thorax will affect cardiac hemodynamics. In fact, more importantly, it's the intrathoracic pressure that affects your hemodynamics in this system. So basic concepts. So when you inspire, whether it's spontaneously or with a ventilator, inspiration increases lung volume above end expiratory volume, and that carries an increase in pressure. That's why when you're looking on a pressure time curve, every time you inspire, the pressure goes up. When you inspire spontaneously, that causes a decrease in your intrathoracic pressure. That's how you drive air into your lungs when spontaneously breathing. So remember, when you inspire spontaneously, your diaphragm goes down, your thorax goes out and to the side. So that creates a negative pressure, and then air rushes into the lungs. This is completely different when you're doing positive pressure ventilation. In positive pressure ventilation, the intrathoracic pressure increases because the force that's driving the air in comes from the ventilator. So to a certain extent, it's just like breathing like a frog, where the frog gasps, takes in a big gulp of air, and that forces the air down to the lungs because frogs don't have diaphragms. To a certain extent, that's what a positive pressure ventilation does. It rams in air into your lungs so that your diaphragm goes down because of that, and the intrathoracic pressure goes up rather than going down. So next case, a 1-month-old boy was admitted to the PICU intubated after placement of a BP shunt. The patient is on a PEEP of 5 cm water. Question: how much of the PEEP is transmitted to the intravascular intrathoracic pressure? 1, lower than 5 cm water, 2, 5 cm water, 3, higher than 5 cm water, or 4, not enough information provided. Okay, any guesses? Okay. So there's not enough information provided. An important thing to remember when providing positive pressure ventilation, the amount of pressure you're giving is not always the same as what's transmitted in the intrathoracic space. So your mean airway pressure, PEEP or PIP, does not necessarily mean that's what's going to go into your intrathoracic cavity. And this diagram actually summarizes that. So your y-axis is the amount of pressure transmission, and then your x-axis is the compliance of the lungs. So what it says is the more compliant your lungs are, the higher the pressure transmission. However, if your lungs are very non-compliant, then there's only a small percentage of the pressure that's going to get transmitted. So going back to the case, so if that patient has very good lungs, meaning no lung disease prior to coming into surgery, then if you give a PEEP of 5, then with a very good lung compliance, then most probably 100% of that pressure is going to get transmitted to the intravascular structures. However, if that patient has chronic lung disease because the patient was ex-preemie, then you expect that the compliance of the lung is very low, and the amount of pressure that gets transmitted is also very low, such that it can only be like, out of 5, maybe only 1 cm of water is transmitted. And why is this important? Because when we talk about cardiopulmonary interaction, it's really the amount of pressure transmitted to the intravascular structures that's important. It's not the airway pressure that you're delivering, it's the amount of pressure getting transmitted. And again, the amount of pressure that gets transmitted is dependent on the compliance of the lung, among other things. You can also have resistance in your airways, but it's typically your lung compliance that's the issue. So one of the ways, so for example, we have a patient who, we have no idea what the actual pressure that's getting transmitted. We have patients with bad ARDS and just no idea. We're going up and up on our fluid resuscitation, and things are still seem not doing well. So what we do is we put an esophageal manometer. Remember, the esophagus is an intrathoracic structure, and the thought is that should also pick up the amount of pressure that's getting delivered into the intravascular structures. So our poor man's esophageal manometer, there are really like fancy esophageal manometers out there, but what we typically do is just put an NG or an OG tube and then keep the tip rather than going into the stomach. We put it like midway in the esophagus, and then we put fluid in there and then hook it to a pressure transducer. So the amount of pressure that you're going to pick up from that manometer can be used to estimate the intrathoracic pressure. Okay, next case. So we have an 8-month-old boy with unrepaired large VSD intubated for pneumonia. Due to worsening oxygenation, PEEP was slowly increased from 5 to 10 to 12. And then as you're increasing the PEEP, the blood pressure started going down from 100/60 to 80/50 to 60/40 with worsening systemic perfusion. Question: what's the cause of the decrease in blood pressure? An increase in PEEP increases PVR. An increase in PEEP increases afterload. An increase in PEEP decreases preload. Increase in PEEP impairs ventricular interdependence. So type in your answer. Okay, some more answers. Okay. Okay. Okay, so the correct answer is 3. You guys got it. Before I move on to answer number 3, we're going to discuss later that the effect of PEEP on PVR or pulmonary vascular resistance is actually variable. PEEP decreases afterload rather than increasing your afterload. And then the effect of PEEP on ventricular interdependence usually is not a big issue. Okay, so I'm not sure if you can see this line going down to the x-axis, but this graph shows your intracardiac pressure, the right-sided heart pressure, and then venous return on your y-axis. So mathematically, venous return is the difference between MS, or your mean systemic filling pressure, minus right atrial pressure times 1 over resistance, or the difference in your pressure divided by resistance. It's the same formula for Ohm's law of hemodynamics, where pressure is equal to flow times resistance. But for our purposes, the most important thing is that when you increase your intrathoracic pressure, and that pressure gets transmitted to your right atrium, so your pressure goes up, so it goes to the right. Your mean systemic filling pressure, which is somewhere here, so the delta between those two decreases, and then if you project it up there, then your venous return decreases. So positive pressure ventilation decreases venous return, and this happens because of an increase in your right atrial pressure. So what about the right ventricle? So again, when talking about cardiopulmonary interactions, sometimes the effect of positive pressure ventilation is different in the atrium compared to the ventricle. For the right side of the heart, the more dominant effect is in the right atrium. That's why I showed you the graph earlier. But positive pressure ventilation can have some effect on your right ventricular filling. A decrease in your airway pressure can decrease venous return, which is opposite to what we discussed earlier. And then, however, but an increase in your airway pressure may increase pulmonary vascular resistance, and that would increase your end-diastolic volume. So just to repeat that, so your end-diastolic volume with a decrease in airway pressure may cause a decrease in your venous return and decrease in your RV/EDV, or the positive pressure can actually increase your PVR and cause an increase in your RV/EDV. Well, you know what? Let me correct that. This is wrong. So an increase in your airway pressure, so an increase in your airway pressure can cause a decrease in your venous return. So again, this should be increased. Increase in airway pressure can cause a decrease in venous return, which is what we saw earlier, or the same increase in airway pressure can cause an increase in PVR, causing an increase in your RV/EDV. Or if the two effects may cancel out, and your RV/EDV may be the same, maybe unaffected with an increase in your airway pressure. Sorry about that mistake in the slide. So some vignettes. So in order to decrease minimize the hemodynamic effect of positive pressure ventilation on the right side of the heart, some things that you can do are, you can increase your expiratory time. When you increase your expiratory time, then that means you have a compensatory decrease in your inspiratory time, so your mean airway pressure is going to go down. So there's less positive pressure on the right side of the heart, and you have better hemodynamics. You can decrease your tidal volume. Again, a decrease in your tidal volume will cause a decrease in your mean airway pressure and better hemodynamics. Or, as the surgeons would love it, just avoid PEEP altogether. But you know, this is always a contention between our intensivists and the cardiac surgeons. Our surgeons take PEEP, but there's actually an appropriate way of giving PEEP. And then lastly, if you don't have any choice and you can't play around too much with your ventilator, then you can infuse intravascular fluid. So that increases your pressure in your intravascular space and actually improves your cardiac output. Okay, so going back to this case, the 8-month-old boy with unrepaired large VSD. So next question, what's the best way to improve systemic perfusion in this patient? Increase eye time, decrease tidal volume, remove PEEP, or infuse intravenous fluid. Remember, I'm looking for the best way to improve this patient's systemic perfusion. Okay, type in your answers. Okay, so the best answer is actually to infuse intravenous fluids. So why not increase your eye time? So as I mentioned, if you increase your eye time, your mean airway pressure increases, and that actually worsens your perfusion. You can decrease your tidal volume, but I don't know what the patient's initial tidal volume is. So what may happen is, if you decrease your tidal volume, you actually increase your acidosis, and that's much harder for the right ventricle. And then third, the reason why removing PEEP is wrong is because you have a clinical reason why you want to go up on your PEEP because of your oxygenation issues. So removing PEEP, while it may help your blood pressure, may actually be bad for the patient overall. So the best answer for this question is infuse intravenous fluid. Next. So a 4-year-old girl returned to the ICU after her Fontan operation. Initially, her stats were 94% on room air, which slowly decreased to 85%. Chest X-ray showed right upper lobe atelectasis. PEEP was slowly increased from, I think that's 5 to 6 to 8, with saturations at 85, 95, and 88%. Question, what is the cause of the lower saturation at 8 cm water? One, PEEP is always bad for post-op cardiac patients. This, I'm telling you, this is what the surgeons would always say. FRC, or functional residual capacity, is exceeded at 8 cm water and thus increased pulmonary vascular resistance. Patient is dehydrated. And lastly, afterload is increased at PEEP of 8 cm water. Okay, some more answers. Good. Okay, so you got this one right. So I guess you're very familiar with the effect of PEEP on pulmonary vascular resistance. So just to summarize the effect, this is a classic a graph showing the effect of lung volume or pressure, depending on the compliance or PEEP, and its effect on pulmonary vascular resistance. Remember, the effect is U-shaped, such that your pulmonary vascular resistance is highest when you are below FRC and when you are above FRC. One way I try to remember that is, for example, you have 4 balloons slightly inflated side by side. Your intraalveolar vessels are the vessels between 2 balloons, and then your extraalveolar vessels are the vessels inside the balloon. So if you hyperinflate the lungs, the pressure between the inflate the balloons, the pressure within 2 balloons or your intraalveolar vessel is much higher, therefore your resistance goes up. But then at the same time, the space inside the 4 balloons actually increases, and therefore your resistance goes down in your extraalveolar vessel. So when your volume is above FRC, it's the increase in resistance is secondary to an increase in the resistance in your intraalveolar vessel, which is the opposite when you deflate the balloons. When you deflate the balloons, the pressure within the two balloons is actually less, so the resistance is less. However, the space inside the four balloons actually decreases in size. So the pressure goes up, and that's your extraalveolar vessels. So the increase in PVR when you are below FRC is secondary to extraalveolar vessels, while the increase in PVR with hyperinflation is secondary to your intraalveolar vessels. So just to summarize that, so positive pressure ventilation can decrease PVR. The reason the diagram I showed you earlier is just one of the reasons for doing that. But by improving your arterial oxygen, alveolar oxygen content, you actually minimize hypoxic vasoconstriction. So by improving your oxygenation, your PVR decreases. You re-expand your collapsed alveoli. Again, when your alveoli are collapsed, then your PVR is increased. You also have your component of hypoxia in that particular alveoli, so that goes back to this point. And then with positive pressure ventilation, you can actually improve respiratory acidosis. And as you know, acidosis increases PVR. So if you correct your acidosis, then your PVR decreases. And then there's also some effect in your central sympathetic tone, but this is not well documented. However, when you give positive pressure ventilation above your FRC, then you go the other direction. It overdistends your alveoli, and that also increases your PVR, again, by compressing your intraalveolar vessel. And this effect is actually more pronounced in patients with cable pulmonary anastomosis, like your Glenn patient or your Fontan patient, because the blood flow to the lungs are passive in these cases. So just an increase in your PVR is actually detrimental to this patient. So a vignette. So one of the ways to minimize your PVR is when we're looking at the pressure volume curves. The volume is in the y-axis, pressure is in the x-axis. We want to ventilate these patients within this area. So we avoid atelectasis, which is at this point, and then we avoid hyperinflation at this point. And as I've shown earlier, your FRC is probably going to be somewhere in this area. So you minimize the peaks in your PVR, and hopefully that's better for your patient. And then the other thing that you can do is you can always give some more intravascular fluid just to improve your hemodynamics. Okay, so going back to this patient, 4-year-old after a Fontan procedure with SATs going down when you went up on your PEEP. So what's the best method of improving this patient's saturation? Extubate patient right away, decrease PEEP to 6 cm water, infuse IV fluids, increase PEEP to 10 cm water. I'm looking for the best method of improving saturation. Okay, so people answered either 2 or 3. I would say just go down on your PEEP to 6 cm water because you already know that the SATs were actually very acceptable at a PEEP of 6. Infusing IV fluids is not a bad idea, but I think just going down on the PEEP is better. I'm a minimalist, so if you know that 6 works, I would just go down and try avoid giving more fluids. Again, one of the issues in POSA patients, they can be very fluid overloaded, and you may have issues taking that extra fluid out. But this is not a completely absurd answer. Okay, next question. So a 10-year-old boy was initially intubated for presumed viral myocarditis with decrease in myocardial contractility. The patient has been intubated for about 5 days and clinically improved. Without changes in inotropic support, patient was extubated, and within 30 minutes of extubation, patient had very poor perfusion. So question, what is the cause of the patient's decompensation? One, nurse discontinued milrinone without informing the medical team. 2, afterload increased after removal of positive pressure ventilation. 3, preload decreased after removal of positive pressure ventilation. And 4, PVR increased after removal of positive pressure ventilation. I'm going to tell you that 1 is not the correct answer. While this may happen, hopefully that wasn't the case for this one. Okay. Okay. So the correct answer is afterload increased after removal of positive pressure ventilation. I saw one who answered 4, PVR increase after removal of PPV. That may also be possible, but we just don't know what the child's FRC is. And again, it can be anywhere. So the good thing with positive pressure ventilation when you're dealing with cardiacs with poor myocardial contractility is that it's actually very good for your left ventricle. So if you think about it, the way you manage congestive heart failure is you give them diuretics because you want to decrease their preload, and you want to give them an afterload unloader so that you're practically helping the heart. And these 2 things can actually be achieved by positive pressure ventilation. So if you put someone on PPV, your venous return decreases. So that pretty much achieves what you're trying to do with your diuretics. And then the other thing is it decreases your afterload, which is what, for example, an ACE inhibitor would do for this patient. The reason for unloading the left ventricle or decreasing your afterload is based on a decrease in your transmural pressure. And that is described by Laplace law and shown in this image on the right. So wall tension, which is the amount of tension that the heart is doing, is directly proportional to the difference between your intraventricular and extraventricular pressure. So think of it this way. Remember when I told you that when you're spontaneously breathing, your intrathoracic pressure is negative. So your intrathoracic pressure is actually your, oops, sorry about that. So your intrathoracic pressure is actually your extraventricular pressure. So if you're breathing spontaneously, your ventricle is getting pulled away from the lumen. But if you're giving positive pressure, then it's actually positive going into that direction. So when you have positive pressure ventilation, the difference between PO and PI actually decreases, and if this factor decreases, then this decreases, and that's actually more less work for the heart to do. Another analogy which I tend to use is if you're trying to, for example, so your hand is in front of you and you're trying to push them together. If someone from outside is trying to help you push it in, then it's easier for you to collapse your, to put your hands together. But if someone is from outside pulling it out, then it's much more difficult. That analogy of someone trying to pull your hand out is the same as with spontaneous breathing or with a negative intrathoracic pressure. And if someone is pushing it from outside going inside, that's the same analogy as when you have positive pressure ventilation. And I think if you remember that analogy, it's easier to understand how positive pressure ventilation improves or unloads the left ventricle. So as I mentioned, so with positive pressure ventilation, it actually abolishes the negative swings in your intrathoracic pressure. These negative swings are much more exaggerated in patients with pulmonary diseases. And that exaggerated swing, decrease in your intrathoracic pressure is actually very bad for your heart. It just increases your myocardial growth. In terms of left ventricular filling, so this is less of an issue for the left side of the heart. So the effect of positive pressure ventilation on the left atrium is much less. It's dependent on the right ventricular filling because the left and the right side are in serious connection, and we're going to talk about ventricular interdependence later. But with positive pressure ventilation, depending on whether you're inspiratory or expiratory, that can have some effect on your left ventricular filling pressure. But again, as I mentioned earlier, this is very minor. What you need to remember for the left heart is the effect on the afterload. Okay, some vignettes. Positive pressure ventilation may improve left ventricular performance, and this is mostly seen in patients with heart failure, such as the case that I mentioned. And then the opposite of that is if you win that from positive pressure ventilation, you can actually precipitate left ventricular failure, and you can also have pulmonary edema. So going back to this patient with myocarditis with decreased myocardial function, what's the best therapy to improve perfusion in this patient? Reinstitute positive pressure ventilation, administer fluid bolus, increase milrinone, or give a dose of furosemide. Okay. Okay. That's correct. So the best therapy for this patient is reinstitute your positive pressure ventilation. And that doesn't mean that you need to intubate the patient outright. We have non-invasive ventilation, such as CPAP or BiPAP, which may actually be just enough for you to tide over the patient until the patient can actually do it on his own without any support. I would be very wary of giving Lasix to this patient unless the child really has very bad pulmonary edema, because with a poor cardiac output, you just might tip the child over. Okay, 4-month-old boy FP intubated for severe pulmonary hypertension resistant to nitric oxide. Patient's perfusion started to worsen without any identifiable cause. Perfusion worsened with fluid resuscitation. So what's the cause of the decompensation after fluid resuscitation? First choice is LV compliance decreased with increasing right ventricle dilatation. Pulmonary edema is worsening. Positive pressure ventilation worsens pulmonary hypertension. Afterload increases with fluid administration. Okay, so just a test-taking technique. Usually the longest answer is the correct answer, and that's true for this one. So the left ventricular compliance decreased with increasing right ventricle dilatation. So typically in patients with severe pulmonary hypertension, they don't end up with pulmonary edema unless it's a venous, pulmonary venous hypertension. But if it's a pulmonary arterial hypertension, it's unlikely for them to have pulmonary edema because the resistance is so high. The effect of PPV on pulmonary hypertension, it actually depends on the amount of positive pressure that you're giving. Again, it's a U-shaped relationship. And then afterload increases with fluid administration, there's really no correlation between the two. So the thing with the two ventricles is that they share a common septum, and there are fibers encircling the two ventricles, such that the effect on one ventricle can be seen in the other ventricle. And this is what's shown in the case that I that I listed. So what happens is with more volume in the right ventricle and the resistance to the ventricle is so high, what happens is that all that extra fluid gets stuck in the right ventricle. And then as that ventricle, the right ventricle enlarges, it pushes the septum to the left. So the compliance in the left ventricle decreases. So whatever blood gets transmitted from the right ventricle to the left side of the heart, it's much harder for the blood to go into the left ventricle because of a decrease in the compliance. The other good thing with the interdependence between these two ventricles is that left ventricular contraction actually contributes or helps the contraction of the right ventricle. The other concept that's slowly coming into play is that patients with very prolonged bundle branch block, they end up in cardiomyopathy because there's just a dysynchrony in the contraction between the left ventricle and the right ventricle. So some people would actually do is measure the QRS interval, and if it's beyond a certain threshold, what they would do is do biventricular pacing so that there's more synchrony in the left ventricular and right ventricular contraction, and that actually saves the heart from getting myopathic. Another vignette on ventricular interdependence. So you can have fluxus paradoxus in pericardial tamponade and severe asthma. And this happens because in pericardial tamponade, the two ventricles are stuck in a constricting pericardial fossa, which is your pericardium. So during inspiration, where supposedly you can increase your venous return to your heart, that doesn't happen because of the constriction coming in from the pericardial tamponade. And it's the same for severe asthma. So what happens is because of the very negative intrathoracic pressure, blood is stuck into the in between the right ventricle and the left ventricle during inspiration because of the very negative intrathoracic pressure. And you can see what happens is during inspiration, you can see a decrease in your cardiac output, which is pretty remarkable with severe asthma. And this may not be a cardiac issue, but in patients with severe asthma, fluxus paradoxus is a very bad prognostic sign because it's just telling you that the obstruction is so severe the patient needs to get a very negative intrathoracic pressure, and it's just another marker of the severity of your asthmatic attack. Okay, so going back to this patient, so 4-month-old preemie with pulmonary hypertension. What's the best way to improve this patient's perfusion? Extubate patient, cautiously give diuretics, infuse albumin, start captopril to decrease afterload. Okay, so these are tricky. So the best way to deal with this one is cautiously give diuretics. Again, I put the word cautiously because you're already dealing with someone with poor perfusion. But what you actually want to achieve is try to decrease your RV, EDV a little bit so that the compliance in your left ventricle improves and hopefully your blood pressure and your systemic perfusion improves after that. This is a case which I actually had before as a fellow, and it's very complicated and it's hard to take care of this patient. I think my time is up. I already finished an hour. I actually have a couple more cases, but I can just send the slides to Sunita, and then she can distribute them to you, so you guys can go over the additional cases. But just a summary, so positive pressure ventilation causes variable effects on the heart. The effect depends on level of PEEP, actually mean airway pressure, volume status, and myocardial condition. And then it's the judicious use of positive pressure ventilation that will achieve the desired hemodynamic effect. Thank you very much. And if you have some more questions, feel free to shoot it. And then Sunita has my email address for